A woman who is in her 8th week of pregnancy sees her family medicine doctor for her first ever prenatal visit. She and her partner spent months trying to conceive. Now she is excited but stressed. Her sister successfully gave birth at home using the water birth method. Meanwhile, her best friend chose to have a planned C-section and now wants her to do the same. Our pregnant friend doesn't want to make the wrong decision and is counting on her family doctor for advice. What should she do? And how can we incorporate evolutionary medicine into the mix? My name is Florence Yuan, and this is Darwin, MD. We learned from the previous episode that giving birth is no walk in the park. Yet billions of humans, mothers and offspring, have survived the process, most before the advance of modern medicine. How did the human species do this, given that there are now almost 8 billion of us? Can we use evolutionary medicine principles to maximize the health and well-being of mother and child during birth? Throughout our evolutionary history, mothers controlled the birthing process. They decided where they wanted to give birth and who to have around them to help. Who did humans choose to help them? Older relatives who had been there and done that. This meant that moms could focus on safely delivering their child in an environment they controlled, with experienced hands at the ready. This makes sense. Studies show that a chaotic or unpredictable environment triggers the stress response and its flood of fight or flight chemicals, lower contraction rates, and in turn, longer labor. Evolutionary responses to that stress compel mothers to press pause, assess the situation, and determine whether they need to move to a less stressful environment. Now, place a laboring person in the technological marvel that is the modern American hospital. Constant beeping of monitoring machines, flashing lights, people moving in and out of the room. It's surprising that soon-to-be mothers don't run in terror from that space. But giving birth in a clinical setting has evolutionary benefits. After all, clinical settings assemble experts who are ready to intervene if something goes wrong, so they are critical for high-risk pregnancies. Hospitals also provide a strong line of defense against vulnerabilities. Infection control tactics, clean hands, clean tools, and clean water are part of the protocol to reduce infant and maternal mortality. In short, our hypothetical patient has good reason to be concerned over her choice. Pros and cons are everywhere, and no consensus exists when it comes to choosing between home and hospital births. Even the definition of low risk varies depending on the region. Ultimately, the patient decides, and only she knows what feels safe and whether she's in control. The most important first step to take is to assure the mom-to-be that stress is normal, and so is information overload. But by following the prenatal care schedule and seeking direct advice from her healthcare provider, she is ahead of the game and should be praised for that. Still, danger in the form of information overload lurks, and we need to help our patient find the signal in the noise. The addition of evolutionary knowledge will help this process to make sure she has as much control over the birth as possible. Our patient has already made an important decision, selecting a doctor she trusts. Birthing is a collaborative process. Patients need to exercise their capacity to select not only the right doctor, but also the hospital that matches their personal values and the nursing staff who can expertly guide her through labor while making sure she stays in control. Of course, complexities are everywhere. Doctors' call schedules, patients' health insurance, and the simple reality of geography all play a role. Many patients won't have the luxury of making choices based on abundant resources. Still, they should try to maintain as much command over the process as possible. Let's say our patient decides to give birth at home. Knowledge of that setting is essential. Systematic reviews of pain relief during labor show that massage, relaxation techniques, water immersion, and non-opioid pain medications work with few adverse effects. These methods are still being studied, but they show promising results, particularly for low-risk pregnancies. However, even if our patient's pregnancy is low risk, it's important for her to be aware that she may need to be transferred to the hospital for a variety of reasons. A 2014 systematic review found that the percentage of women who were transferred from home to hospital during labor varies from 8.2% to 24.1%. Because of that, our patient should try to give birth near a hospital that she can be quickly moved to in case something happens. If our patient lives far away from the nearest hospital, or her pregnancy is higher risk, she will have additional considerations when it comes to labor and delivery. Newborn care immediately after the baby is born is also crucial. The American Academy of Pediatrics statement on planned home birth includes a summary of important guidelines for newborn infant care. Our patient's family medicine doctor should go over these guidelines with her if she plans on giving birth at home. If our patient pursues birthing in a hospital, she can search for one that supports minimal intervention, has low C-section rates, and has quieter rooms to reduce stress. A tour can reveal these and other elements, such as special rooms for natural birth options. Regardless of whether our patient gives birth at home or in the hospital, two practices can greatly improve her childbirth experience. The first is to utilize a simple tool called gravity. A 2013 systematic review found that people who went through the first stage of labor in various upright positions, such as standing, sitting, kneeling, or squatting, spent less time in labor and were less likely to have a C-section or an epidural. The second practice is to have a doula, or birth companion. A 2016 Evidence to Action brief from the World Health Organization states that having a birth companion gives a woman, quote, access to emotional and practical support from someone she trusts. Continuous support during labor may increase the likelihood of spontaneous vaginal delivery, decrease labor time, and improve patient satisfaction with the childbirth experience. Keep in mind that the effects of birth companions can also extend to partners, family members, or other non-medical personnel who may be in the room with our patient. If the mother-in-law is a source of stress, she should not be in the room. Now, for the big question, and one of the main focuses of our patient's stress. Should she give birth vaginally or by C-section? There are vocal supporters on both sides, with some heralding the C-section as the gold standard of obstetric care, and others calling vaginal delivery the only true way to give birth. The truth, as usual, is more complicated than that. On the one hand, vaginal deliveries have been demonstrated to have a variety of benefits for babies. Children delivered vaginally are less likely to develop asthma, allergies, type 1 diabetes, and celiac disease. This may be because mothers pass on a larger and more diverse amount of beneficial gut bacteria to their infants during vaginal birth. The C-section procedure itself is associated with several risks, including neonatal depression from general anesthesia, fetal injury during delivery, and breastfeeding complications. However, there are compelling circumstances when C-sections are life-saving for both mother and baby. Cephalopelvic disproportion and placenta previa, both of which we talked about in the previous episode, are situations that require a C-section. In the circumstance of a breech birth, where a baby is born bottom first instead of head first and can't be maneuvered into the correct position, a C-section is sometimes preferred. If the mother has an active herpes simplex virus outbreak at the time of delivery, the American College of Obstetricians and Gynecologists recommends that she undergo a C-section to avoid transmitting the virus to the baby, which can be fatal or seriously disabling. Twins are often born via C-section for a variety of reasons. Some less life-threatening, but still important risks associated with vaginal delivery include an increased risk of urinary incontinence later in life, and a risk of tears to the perineum, the area between the vagina and anus. Many people want a no-intervention birth, which by definition includes a vaginal birth. This is possible for many deliveries. However, in every pregnancy, regardless of how someone chooses to give birth, she and her team must always be prepared for the potential of a C-section. People should not be shamed for their birth process choices or outcomes. If our patient decides that she wants to have a vaginal delivery, but something happens and she ends up needing an emergency C-section, she should never feel that she is any less of a mother because that happened to her. If our patient has no risk factors that would make her a candidate for a C-section, but elects to have a C-section anyway, she should not be derided for choosing what makes her happiest and gives her peace of mind. Remember how important maternal relaxation and control is for a successful pregnancy and delivery. It's crucial to balance the risks and benefits of different birth practices with the mother's own values and preferences. All modes of delivery are associated with both benefits and harms. No one method is risk-free. In sum, it is important that our patient is as relaxed as possible when giving birth. Preparing for different outcomes long before she goes into labor can help relieve a lot of the stress she might experience as she anticipates the birth of her child. With her doctor's support, she can understand the pros and cons of different decisions and create her best childbirth experience. Thanks for watching Darwin MD. See you in the next episode.